Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Hi, everyone, and welcome to another episode of The Golden Hour. I'm your host, Dr. O, and today I'm joined by Brittany Pruneau. Brittany is a registered nurse, childbirth educator, and the founder of Enlightened Expectations. Through Enlightened Expectations, Brittany is on a mission to empower expecting parents with the knowledge and confidence to navigate pregnancy, birth, and beyond. Her work offers an essential bridge across maternal and newborn care gap in our current healthcare system. Born and raised in Middlesex County, New Jersey, Brittany now lives in Monmouth County with her boyfriend of 10 years and their two beloved orange cat babies. Welcome, Brittany.
Thank you. That was a really great intro.
Oh, yeah. I mean, you're a real easy person to intro quite well.
I like to be simple.
Yeah. And I'm excited for our conversation. I know a mutual friend, Devin, connected us, someone else who's very passionate about the kind of postpartum space. And so when I was asking her about future guests that she recommended, you were top of mind. And so this next hour is going to be such a rich conversation. But let's start with you. What led you to your career now in childbirth as a L&D nurse and even going on to create Enlightened Expectations?
So I'm 35, and most of my life I have suffered from a lot of medical conditions. And I didn't really know about them until I started working as a nurse. I've been working as a nurse for about 8 years. And I found that as I had to advocate for myself, read books, listen to podcasts, and learn what questions to ask my doctors when I go and see them, allowed me to feel really confident in what I needed from my body and what I needed from my mental health.
Yeah.
And I would be able to go to doctors and be like, well, I learned about this. Is this what I have? They would look into it. And eventually they're like, you're right. Let's test you. Let's treat you. And I found that there's a lot of doctors who are wonderful, but there are some who don't really listen. And in maternal health care, that happens very often. The appointments are very quick. And it's not because so much that the doctors want to dismiss their patients.
Yeah.
It's because they don't have the time because they're so busy. And what I can do is give the tools to my clients and my patients on what questions to ask, because a lot of the times when I took care of them in labor or in postpartum, and even in the newborn phase, like a week after postpartum, they would have a list of things that they didn't know.
Yeah.
Over the last 8 years, I really made a list of things that parents wish that they knew. And I created Enlightened Expectations right out of that. And I educate families on everything about what to expect in triage, even just from going from your car all the way up to the L&D floor, like knowing to ask for like a golf cart or something if like you're having really strong contractions.
Yeah.
So it's really important to be knowledgeable about your body and what to expect and what your body is going to go through, but also for the partner to be able to know their role and how to support you and your new baby.
Yeah, so well said. You're totally right. I had the honor of chatting over the phone before we even got to schedule this podcast. That part of what I shared with you was this podcast was born out of my frustration with the healthcare system, that I love my job. It's an honor to serve. It's an honor to be a doctor. That's true privilege. But I'm also in this system that's structured such that my pregnancy appointments, my prenatal appointments are 10 minutes. And my postpartum appointments are 20 minutes. And I think you and I both can agree that that's not the amount of time that people deserve. And in one day, most clinicians, most doctors and midwives are seeing anywhere up to 20, sometimes 30 patients. It's not that we want to be in this, what feels like a machine where you're like, okay, one person next. It's just the way that the system works. And it seems like you've kind of recognized that gap and are trying to fill in as much as possible. And this podcast for me is my own personal chance to like take pause, and rather than this rushed 10 minutes, no, instead each episode is an hour, and it's collection of conversations like this, which I think are so important and enriching for patients and their families. Thinking about your time on L&D, what are some of, you already alluded to, the things that what you see most parents not being prepared for,
Mhm.
not expecting. What are some of the kind of classic, not mistakes, because mistakes I think
Mhm.
have a negative connotation too, but what are some of the classic, unexpected surprises that new
Mhm.
parents have when they get to L&D for that first time?
So sometimes we have patients who are, let's say, this is just an example.
Mhm,
They're about 40, 41 weeks. They go into the office and the doctor's like, let's schedule for an induction.
mhm,
And the patient's like, what is that? So the doctor will explain it. But a lot of the times, again, not the doctor's fault so much, just the
mhm,
timing and the limited amount of time they have to teach, they don't tell the patient that there's four different types of inductions and it can go different ways.
mm,
They don't give them the tools on what questions to ask when they're in the hospital setting, like, what is a Surfadil? How long is it in? You get like a break once it's in for 12 hours. When does it get taken out? What are the precautions to look for? And if it gets taken out early, why? Or even something as scary as a C-section and like a
mm,
mom's already in labor or she comes onto the floor and they're like, "Okay, stat C-section, everyone gets ready." And she's like, "What does
mm.
that mean? Where do I go? What are you doing? What's gonna happen to my baby? Where does my partner support person go? Like, are they allowed in the room?" And I feel like not only should you know what to expect for a quote unquote regular labor, because there's no such thing as a regular labor.
Nope,
Everyone's
I
body goes through
wish.
it different, right?
Yeah,
I
yeah,
mean, some women are they'll go into labor, come to the hospital 5 centimeters, and then deliver an hour later. That's like a miracle, and kudos to them. That's
yes.
incredible.
So happy for them.
I am too, but you should know what's gonna happen and what won't happen
Mhm,
during that stage, but also an emergency C-section,
yeah.
because if you're anxious and worried, like any other average person, I tend to believe that it's very difficult to think straight and ask questions and know exactly what's going on so you can be prepared. For me personally, if I know what's going to happen and I'm not scared of the unknown because there is no unknown because I was educated already, then I'm less anxious.
Yeah, yeah. So well said. No, I think about my role as an OBGYN, and so much of this passion project is pushing myself to be a better version of myself and hopefully inspiring other OBs and midwives to do the same. Is I think about those last couple visits, right? 38 weeks, 39 weeks, 40 weeks, 41
Mm.
weeks. And you never know when someone's going to go into labor. And the favorite question that all patients ask is like, okay, so when's my baby gonna come? And I always
Yes.
joke back that if I knew when your baby was actually gonna come, I'd be like in a mansion somewhere on like the coast of south of France. Like I would be living my best life. But sadly, no
Yes.
one knows that. And again, in limited amount of time, it's hard to necessarily go through all the possibilities, all the caveats, right? Because there's so many
Mhm.
hypotheticals and no one has a normal labor. Everyone has their own birth story, and that story is going to be so unique. And so you can't play out like scenario A, B, C. But I do
Mhm.
agree that, in an ideal setting, you're already kind of laying the groundwork. So for me personally, at that like 39, 40-week visit, I'm saying, hey, by the way, we don't know if the baby's going to come, when they're going to come. For most first time moms, the babies are
Mhm.
fashionably late, right? They come a
Yes.
couple days after their due date. But I'm saying, just FYI, if you're still pregnant by your due date, we're probably going to schedule an induction for a week later. So you lay that groundwork, right?
Mhm.
Then you fast forward and you get to that 40-week visit and like, hey, wow, that baby's really cozy. Let's start thinking about the eviction notice. When are we going to get kick out your baby gently? And then we
Yes.
start talking about the different induction methods. And so for me, it's always helpful to hear externally from someone who's as experienced as you about, again, as well intentioned as all of us clinicians are and how time boxed we are, that we all can still do better. Because as much as I think I do a good job going over the different induction methods, it's really helpful for a patient to kind of sit down and hear that in detail. And maybe even though I say it and I give them the bullet points of you might get mesoprostol, you might get the dilating balloon, you might get dilators, you might get pitocin, you
Mhm.
might have your bag of water broken. That's still probably said in like a 5 to 10 minute span, and they probably just like, but what and huh? And she said Cook's balloon? Like, she's gonna cook a balloon in my body? What did she say? And so
Yes.
being able to step back and talk to either someone like you or a doula or someone and spend 30 minutes to talk about each option, I think would be, so valuable.
Mhm.
How do you think about preparing a client or a patient for an induction. So when let's think about a mom who's coming in,
Mhm.
and you're going to care for them at their induction, and yes, they know that they're there either because maybe they're being induced because of diabetes or being induced because they're 41 weeks.
Mhm.
What do you do in that first, that first admission where you're going through the paperwork? Are you laying the land about what to expect with induction? How are you counseling that patient?
So it's a lot of information, as you know,
Mhm.
but I've been a patient many times myself.
Yeah.
I've been very sick all the way from being septic and making it to just having like a
Mm.
respiratory infection. And
Yeah.
I've learned so many different types and forms of nursing. I
Mm.
also took care of family members, and I'm a nurse, so I've seen all different angles, and I feel like I can
Yeah.
truly empathize. Typically, I would say, "There's a pile of papers here. We don't have to go through them right now, but I'm gonna sit down, we're gonna talk for a little bit." And whether this is labor or this is postpartum, I kind of had the same spiel.
Okay.
I always ask if I can knock on their door, explain who I am, sit down with them, put the papers to the side, and I say, "This is what the plan is." Not I don't say this is what's going to happen. I said, "This is the
Mm.
plan. This is
Mhm.
what the doctors and I are thinking. This is these are the precautions, the risks, and these are also the positives that can come out of it." And even
Mhm.
though the doctor already went over it with them, I can kind of detail it and then explain it in a more personable, relatable level. Not
Yeah.
that the doctor cannot, but again, they're going from room to room. They're probably so busy. They're like, just go over everything with them." I'm like, "Okay, you got it."
Yeah.
And when I do the admission, even something as simple as like, "Here's a gown, open to the back. You can void in this cup,
Yeah.
and I'm gonna have the door closed and the curtain closed for when you come out for privacy." It's constant reassurance.
Mm.
And I tell the partner, the support person, "Put your bags over here. You can sit down and relax for a little while. I'm going to spend time with you guys," just to create a calming environment. I ask
Mm.
them if they brought lights, if they brought a diffuser. I teach them about that. So, my first priority is to make sure that they're comfortable. The
Mm.
second
Yeah.
priority is, of course, well, first is safety. And then second is comfort. If it's a
Yeah.
rush thing, I make sure the baby's on the monitor and mom's okay. But if it's an induction, then comfort, and then put her on the monitor, do her vital signs. And, when they first walk in, they're so nervous. Their heart rate's high. Their blood pressure
Yeah.
is probably higher. So I'm not trying to check their blood pressure immediately. I just want them to feel like this is going to be your home for the next 5 to 36 hours, kind of
Yeah.
dependent on what it is.
Yeah. No, you're so right. For so many women, when they go on birthers, when they go to the hospital for the first time, it's their very first time interacting with the healthcare system because I know you've shared your story and I might ask you more questions. It's
Sure.
okay that if they've been lucky, fortunate enough to be relatively healthy, they haven't necessarily interacted with the healthcare system beyond maybe the regular checkups, let alone
Hmm.
being in the hospital. And I recognize, and I say this to patients all the time, I work in a hospital, so I don't have the same relationship with the hospital they might, where I see it as my place of employment. I don't walk in and
Hmm.
my heart doesn't start racing. Maybe it does if I know it's gonna be a busy shift, so it's a
Yeah.
different reason, but I'm not necessarily, have the same level of anxiety or anxious about the same thing. Versus for
Hmm.
them, you're in this hospital environment. Their usual concept of a hospital environment is when it's someone's unwell or there's an emergency, there's something scary, and so I really do agree that creating a space of safety, of calm and reassurance is so, so important. Thinking about your personal journey, you alluded to already something that sounds really scary. So sepsis. So for
Hmm.
those who don't know, that's like kind of the most serious version of an infection, and if not
Hmm.
treated adequately and quickly, can lead to some really serious sequelae, so really serious outcomes. What was that experience like for you, and what did it teach you in terms of advocating for yourself and feeling
Hmm.
empowered? Of course, acknowledging that when you're septic, you're
Yeah.
too ill to do that, but when you reflected on that experience.
So, as I grew up, I realized I had a lot of gut issues, some
Mm,
inflammation. I never really felt well, some bloating. And every time I would eat certain things, I just didn't feel right. So,
yeah,
every year for about 5 years in a row, I would get the
yeah.
flu and strep throat, same time. And
Mm,
it was simultaneously every March or April. And I was like, this is very strange. Like, our immune system, our hormones, everything lives in our gut. And if we're
yeah,
not feeding ourselves the foods and the nutrients to heal ourselves and maintain our gut, we're actually causing something negative to occur.
Mhm.
And we all know, like, our food system is not exactly the best. We have options, to put
Yeah.
it lightly. And so I learned what it was like to have whole foods, and I learned what my food allergies were. But again, it kind of I went in and out of doctors' offices, and then I found the doctors that were appropriate for me. And in between all of that, the one time that I did get strep throat and the flu, the antibiotics were not working.
Oh,
My fever
geez.
kept accumulating. And my boyfriend, we've been together about 10 years. He knows me very well. He's
Yeah.
like, "I think we need to go to the ER."
Oh.
So he took me to the ER. I barely made it to the front desk without fainting.
Oh my
And it
goodness.
was very, very scary at the time because I was blacking out. My eyes were open, but I couldn't see anything. And
Yeah.
even in the midst of danger and fear, I'm someone who makes jokes. Like, I acknowledge what is
Oh
happening,
god.
but it's kind of a coping mechanism for me.
Oh, I understand. Yeah.
So I kind of made a couple jokes once they called a rapid response and emergency in the ER, and I was laying flat on the bed, and I hear someone behind while all these doctors and techs and nurses are working on me, I hear
Uh,
someone on the other side of the curtain say
yeah.
to Vinny, my boyfriend, "Do you know what sepsis is?" And he's like, "I have no idea. What's happening?"
Yeah.
So for sepsis, you and I know that it is 3 antibiotics. So
Yeah.
that's the protocol for those who don't know is you get 3 antibiotics. They monitor your input and output as far as fluids. And within about like 10 hours, I was feeling a lot better. The
Good.
impact that my body had against myself was
Mm.
due to after this episode, I found out with the right doctors, I had leaky gut.
Mm.
Your gut has little holes in it, or anything that's not getting digested seeps out.
Yeah.
And I also had small intestinal bacteria overgrowth, so bacteria in my small
Mm.
intestine. So my
SIBO.
body just
Yeah.
wasn't functioning the way it needed to. And
Yeah.
my body going into sepsis was its way of telling me, "You're in danger. We need to fix yourself."
Jeez.
So ever since then, I've lived a very calm, holistic life. I eat whole foods. If I ever eat artificial foods, it's more like cookies or chips, but they
It's a
don't have
little treat. Yeah.
little treat, but they don't have those bad seed oils and anything in there. So I bring that approach also with a lot of my clients, and
Okay.
I'm not a nutritionist by any means, but I have the idea of, like, what's good for everyone's body individually, and I do work with them, and if I don't know
Yeah.
something, I educate them on how to advocate for themselves and find someone that suits their needs and what they need. And with my education, not just foods, but of what to expect, if they know what questions to ask and so do the partner, and the partner knows the patient's love language and what they need in the time of what's that word I'm looking for? When they're just not mentally there and they need a little bit of guidance,
Yeah.
a little bit of
Yeah.
support. I feel like advocating for themselves in that way is a really good tool to have.
Yeah, I totally agree. Well, goodness, Brittany, you're a living example of your own strength and resilience. Yeah, you
Thank
and I
you.
both know working in healthcare how truly scary sepsis is, especially if you're
Mm,
arriving in the emergency room and they have to call a rapid response. That means
yes.
you are kind of on the edge in terms of being in, yeah, probably even close to even septic shock if they had to do so many things so urgently. So
hmm
I'm so glad to be talking to you, most
Me too.
importantly. And I
I
think
like to
it's,
say I'm invincible, but I don't know if I am, but I like to treat my body as if I am. Like, I wanna be a
yeah.
machine.
Yeah, yeah. No, no, this is we are so privileged to have these vessels, if you will, and we have to take care of them. But I think what I'm inspired by you the most too is that you're paying it forward, right? So
Mm,
you're taking an experience that could have been really scary and could have like left someone kind of stopped in their tracks, and you're saying, no, I bounce back from this, and how can I make other people feel strong in those acute moments that can feel
mhm.
really fearful? And if the patient can't advocate for themselves, how can I empower their partners to do so? So you alluded to the kind of the right questions, and I put that in quotes because we all know that there's not a right of anything. There's not right or wrong because it's
Exactly.
all individualistic. But when you when you think about prepping a client for whether it's let's start simple, prepping a client for labor and delivery,
Mhm.
whether it's induction or their natural labor, what are those ideal questions? Like if you say top 5 questions that that person should ask their primary OB provider about what to either expect at labor and delivery or what to expect in childbirth.
So when you ask me that question, a million questions pops into my
I
head, so
know,
it's
I
really hard to
know.
dial it.
If you could say, like,
But
these are, like, the most important questions to ask, which I agree, like, part of our job is recognizing there's so many nuances,
mhm.
but if we could kind of narrow it down.
Sure. So I always want them to know their body and know that
Mm,
pain can either be very extreme or minimal. Everyone has different pain receptors.
mhm,
So I want patients to know that there's different forms of pain control and pain
mhm,
management. Pain may not go away completely. So ask the doctors the question, what is the difference between the epidural, between morphine through the IV? When can I get them? What's the latest? So I guess if I were to ask a pain question, there's like a bunch of mini questions with that.
yeah,
Another question is what type of induction am I getting today?
mm,
And is it the same one that the doctor mentioned in the office previously? And will I be able to eat, drink, and go to the bathroom? Another question is, what are my partner roles? Like, what can he do for me? Which is something that I do go over in my program even beforehand. So when the partner
yeah,
or support person gets there, they're like, I already know what to do. The nurse doesn't even
yeah,
need to tell me.
yeah,
Um, and who's in the room? Who's in the room for the delivery?
mm,
I think that's very important because most patients are very anxious, which this
yeah,
is a whole change to their world. Their baby is coming out of their body,
yeah,
which is still incredible.
yeah, it's beautiful.
So I want patients to ask, who's going to be in my room for the delivery and why? And what is the purpose? And what
Mhm,
happens if my baby gets stuck? What are my options? And can you please give me the permission from my body if you need to do something? Like in
mhm,
episiotomy, you have to ask a patient for permission.
mhm,
Um, so those are just a couple of things that I would like to ask. And I guess the fifth one would be if there is a C-section, what is the indication and
mhm,
how long does it take? And am I allowed in the room, like the partner asking that question?
mhm, mhm. So many great questions. I know that each question, even as I'm listening as an OB, I'm like, and yeah, and then each question is a bunch of bullet
Yeah,
point questions underneath them. So thank you for even daring to narrow it down to 5.
sure.
But yeah, I mean, I think I think that's why so many people come into pregnancy and birth, and we haven't even touched on postpartum yet, with a
Mm,
lot of fear. I think the goal of the podcast and hopefully this conversation is to help distill that fear as much as possible, because when there are so many unknowns, that can be so overwhelming that for most of us, again, this is maybe a place of privilege, but for most of us, we do have a locus of control, right? You
mhm,
have learned, unfortunately, the hard way how important your gut flora is for your full body system, which means you're very particular about what you put into your body. You can control it.
mhm,
You shop at certain places, you prepare your meals in a certain way, right? Most of us live in this way where we choose where we go, when we go, how we get there, etc. And then you show up at this hospital, a room full of strangers where you know, well, okay, I'm going to have my baby. I know that that's the one endpoint, but I have no idea how I'm going to get from point A to point B. And
mhm,
how do I feel safe in this, knowing that some of labor and delivery and what I counsel patients on is giving up some of that locus of control. So that delicate balance of knowing that you can't control every time point, but the
mhm.
questions, that understanding, that is empowerment. That feels like strength to me. That feels
Yes,
safe and secure. It's okay. Wow, I've been pushing for 5 hours. I really thought I was gonna have a vaginal delivery, but the doctors tell me that the baby's tired. I'm feeling tired. Okay, I'm gonna have to get a C-section, but I'm not scared because I asked the right questions along the way, right?
yes,
And I would love my goal, maybe it's a naive goal of mine, is to help people feel less of that fear and feel empowered. Like if I have a patient who I've been caring for, I'm lucky we work with midwives. I don't know how your hospital is, but
we do.
we are kind of oh, awesome. And the midwives are great. They're the experts in like normal physiologic birth. And so I know when I'm getting tagged in as a doctor, something's gone awry, not perfectly as planned, right? And so I'm
Mhm.
coming to patients knowing that they're kind of like, oh God, the doctor's in the room, what's happening? But
Yes.
when I kind of make a patient feel like they've truly been heard and they've truly understood kind of why I'm here and what I'm offering, why,
Mhm,
this stage, whether it's recommending, starting Pitocin or recommending a C-section or an operative delivery, whatever it is the best thing for her and her baby, then I've done my job right?
Yes.
My job is not to come in there with a paternalistic, kind of really strong in your face attitude, like, "Nope, I'm the doctor, you're listening to me, let's go."
Mhm.
Heck no, I haven't served that person well, let alone their partner, but when I have those patients who say, "Wow, thank you. Like, we get it. This
Yeah.
is not what we planned, but, like, we feel like you've heard us fully and we are okay with this," then I've done
Mhm.
exactly what I meant to do. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB/GYN doctor. I aim to empower moms and moms to be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so it can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. So Brittany, how do we help providers like me create more space? What should we be doing? I think I'm good at it. I think
Yeah.
I'm pretty good at it, maybe better than most, but I always know I can be better. What feedback can you give us as providers?
So I feel like I understand your energy and your vibe, and I feel like any one of our patients would be so lucky to have you as their provider. So I just wanted to say that off the bat.
Thank you.
I think we really resonate and we would work really well together.
I agree.
I do think that a lot of providers, not that they forget bedside manner, but they're so
Mm,
focused on this is what needs to happen. They focus on the detail, the information, and numbers
mm,
instead of just looking at the patient
mhm.
and the support people that they have with them and really talk to them in a level that they can understand because there's a lot of medical terms that people don't understand. So this is where the advocacy comes in. Like a lot of our
Yeah.
patients, you can see it on their face when the nurse is at the bedside while the doctor's talking to them. They don't know what the doctor is saying, but they feel too scared to ask. So, and the doctor, I would just wish that those who don't recognize it can just be a
Mhm,
little bit more observant, a little bit more
mm,
aware when they walk before they walk into a room, take a deep breath, remember who you're talking to, play like a little script in your mind of like maybe the patient that you saw at last time in the office. How did they perceive the information you were giving them? And
mhm,
see if you can compare that to how they are now in this instance when they're getting admitted or ready to deliver, still in labor. Just be
mhm,
more observant and aware of like the facial expressions, the body language, if there is any, the room and how it's set up, and really feel the vibe because some
mm.
patients just want strict hospital setting. They don't want to set their environment and they're cool with just sleeping it off, getting an epidural at 2 or 3 centimeters. And that's great. If they know that, that's amazing.
Yeah,
But some patients want to bounce on a ball. They don't want an epidural yet. They want to be hugging over the bed.
yeah,
Time and place, integrity, and remember that the patient is very vulnerable and so is their support person if there is one. And reading the room is really important, is what I'm trying to say.
yeah, I totally agree. I think about I mean, it's small things, right? One of the first things I do when I walk into labor and delivery room is if the lights are off, that means my voice is lower, right?
Yes.
If the lights are off, I'm also checking in, like, if someone is fast asleep and it's not an emergency, you know what?
Hmm.
I don't need to come in. I don't need to disturb this person. They are probably so physically exhausted, let alone their partner, and being able to sleep in the hospital is pretty hard to do with all the noises and the disruptions.
Hmm.
If it is something where like, no, this conversation has to happen now, sit down, right? It seems so small, but
Yes.
when we're standing over someone and peering over them, it already creates this power dynamic that is imbalance. And so I'm
Hmm.
oftentimes looking for the stool in the room that I can sit in. If it isn't there, kindly asking my nursing colleague to bring one over for me so I can actually sit eye to eye with the patient.
Hmm.
And then something that I was taught in my training that I love, and I'll give shout out to my one of my old attendings, Dr. Dry. Instead of asking like, you know, uh, uh, what question do you have or what more questions do you have? You assume that they have those questions. So you say, what more can I answer for you?
Hmm.
Any other questions? It opens up that space of assumption instead of just saying, any more questions? Okay, gotta go. It's like, no, you do have more questions. What more questions can I answer for you? Like
Hmm.
you are allowed to ask more questions. And
I
I
like
keep
that.
asking that until they stop. I say, "What more questions do they have?" And they ask another question. I'm like, "Okay, great. That was a great question. What
Mhm.
more do you have? What more do you have?" To eventually feel like, "I'm questioned out.
Yeah.
I'm dry," because that means that you created this space for them to kind of fix any misunderstandings that they have or feel safe to clarify something, right?
Mhm.
Questions and curiosity can go such a long way. So I appreciate, your gentle call out and reminder.
Mhm. Of course.
Thinking about more specific questions, I think you alluded to that when I asked you that top 5 questions, you're like, "But there's so much more."
Yeah.
So if I think about big categories of prepping for childbirth, and then I'd love for us to transition to postpartum, some big categories that come up are labor pain management and C-section. When we
Mhm.
think about labor pain management, what are some of the kind of top tips that you give your clients as you're talking to them about their labor pain management options and
Mhm.
how to advocate for what they need?
So I go over the entire procedure of an epidural
Okay.
from the half hour before receiving, from the time they ask the nurse that they want it
Mhm.
to the time that the nurse leaves the room once she sees the patient and the baby are perfectly safe on the monitor.
Mhm.
And I tell them sometimes it could be a 20-minute process, sometimes it could be a 2-hour process. It really is just dependent. And I give all those factors and what they depend on. I say to them, this is the procedure. But before the procedure, you have to let your nurse that you're starting to feel like your pain is out of control or you're starting to feel the pain occur more often. Communicating with your nurse is so important. Even if you feel like it's stupid or silly, it's not stupid or silly. Like you
Yeah.
want to create that open floor with your nurse. Of course, you want the nurse to make that environment more comfortable so the patient can ask those questions. But
Yeah.
one of the things I tell my clients too is we have to give you extra fluids before the epidural. And the reason is so it prevents your blood pressure from dropping, which prevents the baby's heart rate from dropping. And
Mhm.
then I go into the fetal monitoring strip and what we see in the baby's heart rate, the normal heart rate levels, and also the contractions and how the baby's heart rate responds to the contractions. I print out the strip, I show them exactly what to expect. And then I teach them about how to sit in the bed, that I'm going to be there for them. They can lean over my shoulder and even if I'm not the labor nurse that day, if I'm just supporting there, I can go over all of that with them too.
Yeah.
About and I always before the anesthesiologist comes, I have always said, "This patient's really nervous," of course, as any woman and a partner would be. "Can you please just detail by detail go over what you're doing?" Even something as a sensation like, "Okay, this is gonna be cold on your
Mm.
back. You may feel a pinch or you're going to feel like a little nerve going down one side of your leg and tell them what's normal and what's abnormal. And as
Yeah.
anesthesiologists or nurse anesthetists, which Devin's sister Kim is one, shout out to her because she's
Oh,
incredible.
yeah.
I love her so much.
Aw.
She's someone wonderful to work with, and I trust her with every single patient.
Aw.
So I just wanted to say that
Yeah.
going over what to expect, I feel like is part of a healthcare professional's duty. It's also your
Amen.
duty, yes, to make sure that your patient feels, again, like what we've said before, comfortable and safe. So after that epidural, we lay the patient down and I say, okay, remember what the stripped and the contraction pattern looked like? This is what it looks
Mhm.
like now. This is what's happening, whether it's abnormal or normal. And I teach them. And if it's abnormal, I'm like, these are the interventions that go along with it if it is abnormal. And then that's for the epidural. And then it's the only other option I believe we give is morphine, but
Okay.
I know morphine, if it's given too late in the labor, it can cause newborn respiratory depression.
Yeah.
So, I know some places use other forms of pain management, but what
Yeah.
do you guys use in your hospital? Like something
Yeah.
else?
You're so right. Every hospital is different. So our team, we probably I always say we have I would say like 4 tiers, maybe even 5. So tier 1 to me is just like the natural methods that you can do. So we talked about like bouncing on the birth ball, leaning over
Mm,
the bed. If you're still able to walk around, walking around the hallways, depending on your labor room. If your labor room has a shower or tub,
mhm,
hydrotherapy, you and I know is so great. And then to me, the next tier is like, okay, I need something to take the edge off. And so we do what we call morphine sleep. So it's
ah,
morphine, but instead of IV, it's given through the muscle. So it's longer acting
mhm,
and a kind of a steady state and given with Phenergan. So that's kind of helps with the nausea, but helps you sleep,
Mhm.
rest, if you will, hence the term morphine sleep. And so you're
Yes.
right, we tend to use that either when moms are coming for labor checks and
Mhm.
they're not dilated enough to be admitted, so we send them home after they get that medication, or early labor or early induction. And you're right that it can be associated with respiratory depression, so
Mhm.
low breathing for a newborn baby. So we try to do it early in labor. And then
Mhm.
to me, the next step up is either fentanyl or nitrous gas. So we're lucky that we have the same laughing gas you could use at your dentist's
Oh,
office. We actually have it on a labor and delivery unit. And so
that's
that's a really
amazing.
nice option. Yeah. That's a really nice option for moms if they want to avoid using like opiate medications for any personal reason, or they really want to avoid an epidural. I've had some moms use it through the pushing stage,
Mhm.
which is very, very impressive. And then fentanyl, which is given IV, which is probably similar to how you guys use morphine, where it's kind of quick acting
Yes.
when given IV.
Mhm.
And usually moms, by the time they get the fentanyl, it's like a bridge to the epidural. So maybe they want the epidural, they've already asked for it, but anesthesiologist has to wait for the fluids to be given. And so fentanyl is
Mm.
helping them kind of manage their labor pain until they're able to get the epidural, or maybe they're still transitioning and not ready for the epidural yet. And so it's really great to have so many options, epidural being the
Mhm.
final frontier, if you will. And
Yes.
it's so important to know those options. I think oftentimes in clinic, again, in our limited amount of time, but we're trying our best,
Yes.
we go over that. We also oftentimes, what I'm really proud is our group gives patients a birth preference template,
Mhm.
so that birth preference template includes pain options on there. So ahead of time, it often prompts the patients to ask me those questions like, "Hey, on that template, I saw you guys said something about this. Like, what is
Mhm.
that? And like, what's that option?" I'm a huge fan of birth education, which is a
Yes.
big plug back to enlightened expectations. And so I oftentimes will say, actually, have you even signed up for a birth course yet? They're like, no, I just thought I was going to wing it. I'm like, this is something you can't wing.
No,
Like,
no.
this is life changing in the best way. So I'm reminding them about the courses that we offer through our health system. I'm telling them, okay, take the course. Once you're done with the course, please come back with me all the questions that you still have so we can do a deep dive about what you
Mhm.
need, right? Because we're all different learners. Like you and I could have gone to the same exact lecture in college and walked out with a very different set of questions, right? And so for
Yes.
me, it's like I want to hear the questions that are apt for you. I believe in that individualistic approach. So after you get the course, after you get the frame of reference to give you that knowledge and fill that
Mhm.
knowledge gap, what's left over, that's when I can really fill in. Oh yeah. So different slew of medications that we offer for pain, but really kind of
Mhm.
trying to think about how do we educate patients on those options. I think another thing that we talked about was C-section. And so
Yes.
sometimes C-sections are known, right? There's those patients who I see where their baby is breech or they've had a
Mhm.
C-section before. So we already know by the time we get to the end of the pregnancy that we have this plan, we have an appointment, we talk about everything in detail. It's very different when it's the plan,
Mhm.
but when it happens in labor and you only had in your mind that there's only one way that baby was gonna come out of you was vaginal, and then you're being told otherwise, that can
Mhm.
be really jolting, that can be really upsetting. How do you prep your clients for that possibility, or even your patients in labor
Mhm.
when you're on a shift for that possibility of the C word?
So first, I want to share my admiration for your tiers of pain level,
Uh,
and the what we can provide for that. Because I
yeah,
feel like even when you asked me, the first thing I went straight to was an epidural morphine, and there
yeah,
are a lot of more natural, holistic ways of doing that, like you've mentioned. So I just
yeah.
wanted to say thank you for
Oh,
that.
yeah,
Um, so if I have a patient in labor and let's say it's about 6 hours, and like you mentioned before, baby's heart rate's not great, mom is kind of getting tired. If it's emergency C-section, I say to the patients, if they don't have education prior, okay, this is the procedure. I'm just going to give it to you straight. And dad, you're going to look like a blue smurf because those are the outfits that we have for the OR,
yeah.
and you are going to be able to be in there as long as
Mhm,
she's not under general anesthesia. I know every
mm,
hospital has a different policy, so that's
mm,
one thing that I want patients to find out before they go into a hospital. What is
mhm.
your policy on dad being in the operating room if it's general anesthesia versus a spinal? And understand the difference between a spinal and an epidural. So if my patient has an epidural already in the labor room, anesthesia will come in, and I explain to them what anesthesia will explain to them. So they kind of hear it multiple times,
Good.
and it releases their nerves a little bit more. You can kind of see them calm
Yeah.
down because one is the pain. is that's the scary part, and the second thing
Yeah.
is mom and baby gonna be okay? The dad's like, "I don't
Mhm.
even care. Just let me be there," and I tell him the ways that he can be there, and he's
Mhm.
gonna be by her head, you can play music, pick a playlist, just say, "Here, doctor, here's my phone, play it," and then
Yeah.
I tell him, like, "Keep your phone nearby, though, because you're gonna wanna take pictures of your baby," and
Mm.
ask them if you can do skin to skin in the OR, like, I give him a lot of tools, and I like that you said the birth preference list instead of like a
Mhm.
birth plan, because
Yes,
a birth plan
girl.
doesn't always go as expected. A
Yep.
lot of times I've seen it goes the complete opposite way.
Mhm.
So, what I tell my clients is if you're going to have a birth plan or a birth preference, just make it as a wish list and
Yeah.
say, I know these are my options. This is what I prefer, but I understand that this is what can happen too, as provided to me by Brittany, who educated me on this.
Mhm.
But I really need patients to take a deep breath and let it out, and it sounds so silly, and it's like, "Why is this nurse telling me to take a deep breath when I'm going for a stat C-section?" And it's just to, like, make your body come out of the fight or flight just a little bit, so
Exactly.
you can just kind of, like, remember, this is emergent, but you have people here who know what they're doing, and they were trained for this, and you can trust them and rely on them, but remember after the fact that you do have tools at your disposal to ask questions. So, I just want
Yeah.
my goal is just for my clients and my patients to feel comfortable to ask those
Yeah.
questions.
Yeah, yes, going back to just that theme, I think it's not only a theme in our conversation, but every podcast episode I've had the honor of doing so far is just about empowerment. Like the
Yes.
goal of I think most of us who end up in this space of maternal health is we want our patients, our clients, their support people in
Mm,
a time that otherwise can feel so scary and so quick and kind of this like whirlwind. Sometimes you want people to feel empowered in that
yes.
whichever way that looks like. And thinking about C-section, you mentioned skin to skin and something that I think I'm really proud of and I hope and I would love to learn from you. I hope
Mm.
more hospital systems are doing is what we call, a patient-centered C-section. So
Mm,
for our hospital, we it has a couple components. One is, the sterile drape that covers the mom actually has 2 layers. So
mm.
one layer you can't see through, the other layer is see-through, so you can actually drop the opaque layer, and
Ah.
I call it the Simba Lion King moment, and I
Oh,
I I
yes.
literally will tell my patients, like, "So do you want to have your Simba moment?" And one patient took me so literally that her husband played that song from
Oh.
Lion King right when I lifted up the baby and the whole OR, like the nurses, anesthesiologists, all of us were like dying. It was one of
Oh,
the best
I love
C-sections.
that.
But it's a moment where we can drop down like the sterile drapes for surgical precautions, but you can actually see the baby. And some parents are like,
Mhm,
actually, I don't want to see my baby in goop. And like that, no judgment there. That's why we
mhm.
check in about it. Like, yeah, like give me the baby when the baby's swaddled up. But a lot of parents are like, I want to see my baby immediately. And the dad's standing up and taking pictures, and it's so cute. The other thing that we do is delayed cord clamping. So even with
Mm,
C-sections, everyone in obstetrics now acknowledges that delayed cord clamping is really important for babies. And so in a vaginal delivery, it can be a lot more controlled. With C-sections, it's still surgery, but we'll do delayed cord clamping for at least 30, 60 seconds.
yes.
Skin to skin you mentioned is so important.
Mhm.
People often ask me like, why is the podcast called the golden hour? Because that first hour after birth is literally the golden hour for so many
Yes.
reasons, and skin to skin is a part of that even for C-section moms. And so we're really fortunate that we've staffed up so that we have extra nurses in the operating room just to help moms with their skin to skin. We've
Mm.
even, obviously with emergency C-section, it's a little bit different, especially if it's really emergency and a mom's under general anesthesia. But if it's, an urgent C-section, not like a true emergency, and they have an epidural already, we can still make it so that the mom can do skin to skin with the
Mm.
baby. All those things are so important and so vital for, again, taking someone's birth wishes and
Yes.
plans that may have not included a C-section, but still creating that loving, nurturing environment within those first couple hours of life when we're
Mhm.
able to. Are you guys able to do, patient-centered C-sections? Do you guys have those protocols at your hospital system?
So we try really, really hard. We
Yeah.
are a baby friendly hospital.
Mm,
We do as much breastfeeding as possible. Again, no
I
judgment if
love it.
patients don't want
Yeah,
to. We attempt skin to skin as much as we possibly can.
yeah.
In the OR, it's very difficult because it's very cold in there.
Yeah.
And we are a teaching hospital, so when a baby
Yeah.
comes out, we immediately bring the baby over to the warmer, and we have a team of people who have to see the baby first. And they'll hold
Yeah.
the baby up so mom and dad can see him or her. But a lot of the times, moms are a little bit unwell and they don't want the baby to their chest, or they don't even know that that's an option because they
Yeah.
weren't told. But we try really hard and we try and keep those ratings up, not for the ratings, but for patients to feel like, "Okay, I got a little bit of what I asked for," and they just are
Yeah.
grateful for it.
Yeah, yeah. No, you're right. There's certain circumstances where mom is too unwell, and then we actually have situations where dads will do skin to skin, like in the recovery
Yes.
room while they wait for the mom and things like that. But I think that it's also helping people understand each hospital is so different. So with my hospital, I know exactly what they can expect. And so in my
Mm,
visits with them, or if it's right before the C-section on labor delivery, I'm still telling them this is what we do. But so whatever hospital system you are in, being able to inform patients and clients, okay, well, this is what to
mhm,
expect. We're at a teaching hospital, so use your hospital for example, which means all the learners on the pediatric side are going to help assess your baby as soon as they're born before you get to see the baby. Like that's all a part of the expectation setting. So I think that's great, and that is, and now I
mhm.
understand why enlightened expectations is in your title of your company because it really is all
Yes.
about expectation setting wherever you are,
Yes.
knowing that every environment is so different, right?
Mhm. Yes, it's
Yeah.
really true. Every environment is really different, and you can kind of feel disoriented. And
Mhm.
sometimes, like for me, let's say like I'm learning something at home, and then I go to my place of work, and I'm like, I learned it at home, but I'm not in the same environment. Like, how do I bring it back into my brain? Like, let me
Yeah.
just picture myself in the room of the information that I was told, and then I can bring that on into my workplace. It's just kind of environmental for me.
Yeah, I love that. As we transition to we've talked a lot about childbirth.
Hmm.
Now we transition to taking that newborn, that precious bundle of joy home and the whirlwind that is, what would you say are the most common misconceptions or myths that you think, you've seen clients, patients have about that newborn period, and
Hmm.
that early motherhood time?
The hardest part is over. Or when
Yeah.
they're still pregnant and family and friends are like, "Oh, but just wait, you won't sleep at night." And I feel like those are so discouraging, those things
Mm,
to say. The hardest part isn't over. I mean, it's very difficult to be in postpartum, and not everyone has a support system. And the whole just wait till your baby doesn't sleep, or, they give like different examples of their own experiences. It really devalues and takes away that experience of those new parents.
yeah.
So they're not myths so much, but they're hurtful for me to hear that my clients come and tell me, "Oh, so and so said this to me, and that's why I'm coming to see you because, like, I want the facts. I know you can be straight up with me. I know you're
Yeah.
going to give me the reality of the situation." And some newborns are great. Some newborns need extra care. And we
Yeah.
have some moms who had a C section and some moms who had a fourth degree tear, which is
Yeah.
horrible. And some
That's
moms who
really
have
hard
no
to
tear at
recover from.
all.
Yeah.
So it's really situational, and having support on board, even if it's for yourself, like freezing your meals while you're still pregnant so you have them for postpartum,
Mhm.
just really preparing yourself. So I guess it's hard for me to answer that question because those things are the first things that pop into my mind.
Yeah, no, I think that's a great answer. And yeah, when you sit down with a client, 'cause I know that you start with them from the start of pregnancy
Mhm,
throughout going even into the postpartum period. What does that postpartum plan look like? How do you help them? Again, we just spent the past like 45 minutes talking about the unknowns of labor. So acknowledging that someone doesn't know if they're going to go home with a fourth degree or a C-section to recover from, that's huge, right?
mhm,
But if you're just giving them like the general, okay, these are the, top categories to help you prep for postpartum and start thinking about, what do
mhm.
you think are the most high yield ways to prep for the postpartum period?
So I am most knowledgeable in the first like 4 days of the newborn's
Yeah.
life.
Yeah.
So the first thing I would say to parents, the first 24 hours, your baby's probably going to sleep a lot, just like he or she. They're exhausted just like you are.
Yeah.
So do we go by feeds on demand? Yes. However, I would still set your alarm. So if you're at the 3 hour mark, you know that get up, go pee, get your pads ready, or have your partner support person get your pads ready while you're getting out of bed, go to the bathroom. And while you're in the bathroom, then your partner can get the baby awake, change his or her diaper, and then you can have a system in place every few hours if the baby's not waking up to eat. and feed the baby. The second 24 hours, babies are very gassy because now you're not the mommy isn't doing all the work for them while they're
Yeah,
inside, mommy's doing all the work for them outside now.
yeah.
The digestive system is activated. They're super gassy, they're fussy, they're cluster feeding, meaning they want to eat a lot more. And if you're breastfeeding only, which kudos, that's incredible.
Yep.
Again, a lot of respect for formula feeders also.
Mhm.
But if you're breastfeeding, baby is going to cluster feed and want to go onto the breast a lot more often. And if the baby's doing that, that tells your body create more milk. Baby's hungry. So it's its natural nature's way of progression.
Mhm.
And also, you're allowed to put a sign on your door and have no texts and no residents. And you're allowed to ask for collaboration of care, meaning if the mom's blood work is due at 5 a.m., maybe ask if the baby's bath and hearing screen can be done all at the same time. So you promote rest, you promote
Mm.
togetherness, and it allows the family to kind of come as one whole family to connect a
Mhm.
little bit more.
Yeah, yeah, I love that. I love that you're really helping clients think about those first couple days while they're still in the
Mhm.
hospital. How do you kind of still advocate for yourself in a hospital setting,
Yes.
let alone kind of recognizing the changes that you're physically going through as you're recovering, and also the changes of the baby. So I love thinking about
Mhm.
like the super sleepy baby to the gassy baby to like the cluster feeding, which is actually very, very normal as
Mhm.
they're kind of figuring out what they need. It's always so funny because sometimes you'll have patients, your C-section patients, they stay in the hospital longer, right? Because it's a longer
Mhm.
recovery. And that first time you see them, like, oh yeah, I'm doing great. Baby slept great. Like this isn't bad. And then you like round on them the next day and they're just like, we didn't sleep all night. Like,
Yeah.
yes, welcome to parenthood.
Yes.
It's not fair when people say you're never gonna sleep. It's taxing in various ways.
Mhm.
Sleep deprivation is real. It is a real part of parenthood, but everyone is different. Some babies really do kind of sleep longer stretches earlier on. Some babies really like need a lot more attention
Mhm.
throughout the night. Some babies just like to cry because they can, right? Like
Yeah.
every baby is an individual, just like every birther has their own individual labor experience. But it's really nice to kind of normalize what you may or may
Mhm.
not expect within those first 4 days and what questions to ask to help get you there.
Yes. And I usually tell them if your baby's crying a lot, just go through the list. Is their diaper need to be changed? Are they cold? Are they too hot? Do they need to eat? Do they just want skin to skin? Sometimes that's all they want. But a lot of the times they want to be like, they're used to the movement inside mommy's body. They're used
Yes.
to the bouncing or the swaying or someone talking to them. So maybe play some music for them of what you listened to while you were pregnant or talk to them.
Mm,
There are so many different simple ways to soothe, but if baby is still not being soothed, call the nurse in and be like, "What are my other options? I've done
yeah.
lists from 1 to 10 and I don't really know." And that's what they're there for.
Yeah. Yeah, I love it. Well, Brittany, we've had such a wonderful conversation talking through kind of pregnancy, birth expectations. Also, you've done a
Mhm,
really good job of including the partners and making sure that we always make sure that they feel supported and prepared for
mhm,
experience. And now within the first 4 days of postpartum, when you think about all the people who've had the honor of being supported by you
mhm,
in pregnancy and through their birth, either again as patients or clients, do you have a client story that you find so inspiring that you are my like, yes, this is my purpose story. Like this is when I showed up as the best version of Brittany, or
mhm.
this is when enlightened expectations really served the client really well. Do you have any of your success stories, if you will?
I like to think of every client and patient as a success story because
Mm,
they each have their own individual, and that may sound a little corny and cliche, but
no.
I'm just think about all the women and the men and the families that I have helped over the last I started this in October 2023,
Yeah.
and I started it mainly for mental health purposes because I also know what
Mm,
it's like to feel sad or scared or anxious while my partner is also supporting me, and he didn't know how to support me during the time, so I knew my love language. I'm like, "Just hold me when I cry," or "Hold my hand," or "Massage my back," and if I can give my patients and my clients the tools to feel safe within their relationship and understand each other, connect and communicate, and also the tools of what to expect at a birth center or in the hospital, I really feel that it truly brings down that nervousness level, and
Yeah.
they feel more bonded than ever. I mean, having a baby can create the biggest bond between two people who
It
already love
can.
each other.
Yeah.
Um, and I just think that when you are aware of your surroundings and your environment, and it truly, I'm trying not to get emotional. It truly bonds me to all the
Mm.
families that I've helped. I had a client who was saying that she felt a lot of back pressure when she went to triage, and they're like, well, we're going to admit you're going in labor, but the baby wasn't descending and going into the right position. And she's like, well, Brittany told me about spinning babies. Can any of the nurses put me in different positions to get the baby in the right position? Because they were talking about a C-section. And
Mm.
I'm not trained in spinning babies, but I know a lot of women who do. So anything that I don't know, I have someone who does know. And that's like
Yeah.
part of my specialty as well. And those
Yeah.
girls are incredible. The girls I work with at Jersey Shore and Neptune, New Jersey, I'm just shouting them out.
Shout
They
out. Yeah.
really allowed her to feel comfortable and safe in her body, and she knew, like, what she needed for her first baby.
Mm.
They flipped that baby, she delivered vaginally in, like, 30 minutes of
Yes.
pushing. And
Ugh,
again, not every situation
amazing.
is like that,
Yeah.
but she knew what to ask because she was educated, and she allowed people to help her, and the partner was able to help the girls be like, "Okay, dad, get this leg," or "Do this," and it was a success story. I had another client who delivered a 9-pound baby vaginally, and
Go girl.
I know, and I had another client who did have an emergency C-section, and they were trying to give her part of our protocol, and it's just like a natural order set that falls in line after a
Yeah.
C-section is giving, like,
Yeah.
oral, like, pills, like Motrin and Tylenol, but
Yeah.
she was, like, extra nauseous than the average,
Aw.
and she knew because of my program, ask for something IV for, like, the first 12 hours, and
Yeah.
when you do that, it allows your body to recuperate, get rehydrated because 'cause you're not, like, vomiting anything up from your unsettled tummy, and her
Yeah.
recovery went a lot more smooth than she had anticipated. So every story to me is
Yeah.
a success, especially when they're advocating for themselves and the partners involved.
Exactly, exactly. You're giving me chills. No, you're right. I think that even if the end of the story isn't what is expected, right? So you acknowledge the person who ended up with a unplanned emergency C-section. But if you feel in those moments that you were able to access your ability to ask questions, to advocate for yourself,
Mhm,
your memory of that, whether rather than it being trauma filled, will actually come back to you as a success story. Will actually come back to you as a, like,
mhm.
yeah, I'm proud of myself story. Like, if
Yes.
you pushing out a 9-pound baby, you should definitely be proud of yourself. Holy crap, that's
Yes,
amazing. But it's even again thinking about those moms who have those stories that don't turn out the way they had planned. I want them to walk away feeling like it was still a success. And I
yes.
think that it's people like you, programs like Enlightened Expectations that are helping people do that. So, Brittany,
Thank
I'm
you.
so grateful for you sharing your just general positivity, your resilience in your own story,
Thank
and
you.
paying that energy forward by helping people feel so empowered in their own birth journey. So, thank you for what you do, and thank you for your time today.
And thank you for being so kind and asking me questions and being inquisitive about what I do because I generally feel like we have a true connection and it means a lot that someone's giving me the time on a Sunday to have this discussion. So thank you so much.
Oh, the feeling is mutual. No, I think, as I said before, I think those of us who are in this birth space, we're all so invested in our patients. We believe in what we're doing. I think
Mhm.
we all want people to feel strong and safe. And so when I meet a fellow kindred spirit, I will gladly give a sunny Sunday to you anytime. So thank you again, Brittany. Really
Yes,
appreciate you.
thank you.
Thank you very much for listening to The Golden Hour, the podcast community where moms and moms to be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.